First of all, thank you very much for coming. I know this is, it's a big deal for you guys to come, and I appreciate everybody coming, but I wanted to introduce myself. My name is John Foote. I'm an orthopedic surgeon here at Saint Al's, and I appreciate Saint Al's marketing team doing a great job for getting the word out, because I think some flyers went out there pretty well done, so appreciate them and appreciate you guys coming. What I wanted to do today, I just wanted to tell you a little bit about myself and why I'm doing this. So I'm an orthopedic surgeon. I've been in town for almost 20 years, just in the Treasure Valley. I'm a board certified orthopedic surgeon with a specialty in sports medicine. I did a fellowship in sports medicine. 20 years ago, I was a sports medicine doctor. I did ACLs and knee scopes and shoulder scopes and rotator cuff repairs. And then as I've gotten a little bit older and as I've gotten a few more gray hair, my patients, for some reason, have gotten older. And those patients who had ACL tears and meniscus tears and cartilage injuries got to the age and got to developed the problems that required joint replacement surgery. So as my practice matured, I matured as a surgeon, started doing more and more joint replacements. And now my practice is exclusively robotic surgery. Super excited to be here. I wanted to talk a little bit about kind of where things have come over the years that I've seen, that I kind of have witnessed firsthand in terms of technology and where we are today. We hear a lot about technology these days. There's a lot of stuff out in the media about robotic surgery. How many people have heard about the Jiffy knee? Anybody hear about the Jiffy knee, the nano knee, the Mako knee? All these terms are being thrown around, and if you Google knee replacement, all these terms will come out. And I wanted to kind of talk through those things so everybody understands where we are in 2025 with technology as it relates to joint replacement and how it can benefit you, okay? The problem, right? Knee arthritis. We're going to be talking about knees today. We could talk about hips and shoulders, but we're just going to focus on knees today. So knee arthritis is when the tread wears out on the tire, so to speak, where you get thin, okay, and the steel belts start showing through. These x-rays up here show x-rays typical of knee arthritis, where the space occupied normally by articular cartilage gets smaller and smaller and smaller until finally the bone touches. Once the bone touches, then you need to start talking about probably knee replacement surgery. How does it work? What we do with the knee replacement is we take the diseased bone, the cartilage that is worn off the knee, we make very specific cuts that correspond to the shape of these knee replacement implants, okay? We size those implants to your anatomy, and then we cover the bone with these metal and plastic implants. And this is just a mock-up of one of those. There's two types of knee replacement. There's a full knee replacement and a partial knee replacement. This is a full knee replacement where we put a plate on the tibia. There's a little keel that goes down into the tibial bone here. There's a cap on the femur, and then there's a plastic shim in between that locks into the tibial base plate. And so you have plastic rubbing on metal, and that's the new knee. There's a partial knee replacement. Some people are lucky enough to have arthritis just confined to one spot in their knee, and we can usually take care of that by putting a partial knee replacement in by either replacing the medial side, the lateral side, or sometimes we'll even do the patellofemoral joint alone if the rest of your knee looks good. So here's some x-rays of a replaced knee. On the left side is the partial knee replacement. What you don't see in the middle here is the plastic shim or bearing that goes in there. We call that a tibial spacer. This is the pre-op, or the other side. And then this is a full knee replacement where you have the full tibial base plate, the full femur, and then a plastic spacer in the middle. Knee replacement, we owe modern knee replacement to the British. Dr. Insall was an orthopedic surgeon in the 70s that developed the first commercially successful knee replacement that looks like modern knee replacement. In the 80s, we took his ideas and we took it to the masses. I was in high school in the 80s, so I wasn't doing this in the 80s, but in the 80s, orthopedics as a profession were developing fairly rudimentary alignment jigs and cutting blocks so that we can standardize our results so that we can make things pretty good. And we got pretty good at it. I think these instruments are still being used today by about half of the orthopedic surgeons in the country are still using these instruments. But we were able to get more consistent results. Some of the companies started developing more sizing options so we could get a better, more custom fit. So this is what we did. We used to drill a hole. That's a rod that goes up into the femur, all the way up in the femur. These are the old instruments. Cutting jig goes on the end of the femur. Distal femur cut is made, okay? That's based on most people's anatomy. It's about 5 degrees with respect to the long axis of the femur. Then we make cuts anterior, posterior, and then we make these chamfer cuts that are kind of oblique cuts on the femur. And then this is the alignment rod we used to use for the tibia. It's an external alignment rod that allows us to kind of Kentucky windage the cut, right? So we put this on and we make a cut that's supposed to be perpendicular. Those are the instruments that we developed in the 80s that are still being used today. Again, half of the surgeries going in the United States are being done with instruments that were developed in the 70s and 80s. And this is what we used to do, okay? Great results. I mean, there's a lot of people walking around with knees and hips that were done like this, okay? Implants go on, happy patient. Okay, let's go to the next one. In the 2000s, I think this top thing in my career is one of the 2 fundamentally transformative ideas or technological advancements that changed the game for orthopedics. In the old days, we used to use this pretty soft plastic for the bearing, right? And we used to do this, it's called polyethylene. It's another term for plastic. We used to do this procedure called polyswaps a lot, where the plastic would wear out and then we go in 10 years later and switch out the plastic, called a polyswap. I haven't done a polyswap in years because in the early 2000s we developed this really strong plastic, highly cross-linked plastic that looks the same when you put it in, when you take it out. It can wear and wear and wear. And so the plastic improved in the early 2000s, and that was probably the first huge step forward, in my opinion, with knee replacement surgery. And then we also developed this muscle sparing approach. Anybody hear about that? Muscle sparing knee replacement? Yeah. So we developed an approach where we don't cut through the tendon, we cut under the muscle. We just move the muscle over, mobilize the muscle. We'll talk a little bit more about that. The problem with muscle sparing is it wasn't widely adopted because there were some problems with alignment. You can't see as well with a muscle sparing approach. Things are a little tighter. And what was happening is knees were going in, out of alignment. They get a little wonky in terms of stability. And so it was adopted and then kind of set aside by most orthopedic surgeons because there were problems. So 2025, robotics has come into place. This is the Mako. We have a Mako right here. This is the real Mako we use here at the hospital. Robotic surgery has made it so we have abandoned those rudimentary implant or instruments that you saw earlier, and we're using state-of-the-art technology to get within a degree and a millimeter of accurate. Okay, and then there's some AI-driven algorithms that we use, that the most recent software iterations are using artificial intelligence to help us make decisions in surgery based on the information we're getting real time. So the surgeon doesn't have to spend time making these complex intraoperative decisions. We hit a button, it gives us a solution. We can review the solution and see if it meets our needs, and then we can move forward based on that AI-driven technology. So it's really exciting. That's the latest software that we have. And we'll show you what step that comes into place in just a second. And then we now can kind of resurrect the idea of muscle sparing approaches because we have robotics that make things so much more accurate. So we don't have to worry about alignment. We don't have to worry about stability because we have the robot helping us get that right. We don't have to see as well because we have the robot. And so we can use that muscle sparing approach that was developed 20 years ago, that didn't quite work out, marry that with robotics, and now you have a limited, a small incision, minimally invasive surgery, muscle sparing surgery. We don't cut any tendons, we don't cut any muscles, we kind of move things out of the way, use the robot, and you get the great result. Okay, so old school long incisions. On the right was an incision done previous, on the left was an incision done, we'll show you that. But average length of stay when I started this business was 4 to 5 days. The new school way is smaller incision. This patient had the long incision on the first knee, small incision on the second knee, and we were getting people out the same day, okay? So muscle sparing versus traditional approach. This is the traditional muscle sparing approach, the medial parapatellar approach, where when we get into the knee, we have to open the knee up, and so we cut the tendon of the quadriceps muscle, and we cut along the medial aspect of the patellar tendon. We just open the knee up from the front. The muscle sparing approach, you don't cut this tendon at all. You actually cut the capsule and you sneak into the knee from the medial side. So this is better exposure, but it's more pain and a slower recovery. This is a smaller incision, less pain, quicker recovery, and when combined with robotics, the alignment and the stability is accurate and works out really well. This is the Jiffy knee or the nano knee. Jiffy knee and nano knee, just to clear things up, is nothing more complicated than a resurrection of this idea of this muscle sparing approach that's been around for a long time. It's just being marketed to the masses. Now, interestingly, those who are touting the Jiffy knee and the nano knee, they're not using robotics with it. So they're using the old instruments with these, just kind of a marketing push. They allow surgeons, if you pay them a fee, to use this brand, and they market for you, and patients get interested, they Google it, and they get your name, and they end up in your clinic, and it's really just kind of a marketing idea. But in my opinion, it needs to go one step further. In order for this to be successful long term, we need to use this with robotics, and then you have a game changer. Does that make sense? So Jiffy knee and nano knee is this. We don't have a term for our knee. Maybe we can call it the spiffy knee. I don't know. The Saint Alphonsus knee. The Saint Alphonsus knee is a nano knee or Jiffy knee with robotics. Okay, it's the muscle sparing knee with robotics. So if you ever see that online, Jiffy, nano, now you know what it is. It's just a new term for an old idea. Okay. Nampa knee. That's good. That's a good one. I like it. Okay. So let's look at the robot and let's just see how it works, okay?
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of X-rays taken at different angles that can help surgeons see things that they can't typically see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Okay, so you see the difference? It's really fun to look at the juxtaposition of the old instruments to the new. This is the second biggest, I think, step forward in knee replacement surgery that I've seen in my career is the development of robotics. And it was a long time coming. We started with computer-assisted knee replacement, which was the precursor to this robotic technology. That's where the computer helped us navigate the pinning of the cutting blocks, but we still used the old cutting blocks. It was just, we would navigate where those would be pinned instead of using the guides. That was step one. And now we have a robotic arm that comes in that's constrained by digital guide rails that keep us in line. I'm still holding a trigger, and I'll show you how it works in just a second. But the robot keeps me in line according to the preoperative plan to help me execute that plan within a degree and a millimeter, okay? So in summary, we got Michael Jackson here doing the robot. I just, first of all, if you're old enough to remember when this was on TV, you might need a knee replacement, but we want to marry the quad sparing approach with the robot for smaller incisions, quicker recovery, out of the hospital same day. Now, not everybody's a candidate for getting out of the hospital the same day. If you've got medical problems, we can keep you, but most people, we have been able to get people home the same day. So, and then that limited approach where we're not cutting the tendon really makes the first 6 weeks a lot better for you. Okay, so we've been at this for 20 minutes. We're going to kind of reconfigure our room here. We're going to go over probably a 15-minute demonstration on the Mako. Then we'll have some time for questions, okay? We start with a CT scan, right? We get a special CT that gives the robot a 3D image of your knee. We upload that image, that information into the software program, and it morphs an image of your knee. This would be your knee. It would be different for every case. It's not. This knee is based on the anatomy of whoever's laying on the table, and we're seeing it real time in the operating room. So we can do a pre-op plan, and we can make an initial assessment of how big it is, how big the knee needs to be, how big the femur and the tibia need to be, where they need to be aligned to get it lined back up at the deformity. We can correct that before we even make an incision. And we have an idea going into the operating room how big it needs to be and where it needs to go. And then when we get into the operating room, we open the knee up. We put these arrays in the bone with reflective mirrors that there's an infrared beam that goes between here on this camera and the mirror, and it bounces back. As we move the knee around in surgery, the robotic arm will move depending on where the knee is, and you'll see that. So once we get into surgery, we can take points on the knee, and we can tell the robot where certain points are, anatomic points are. Can you see that? Okay. Okay. So I'm just going through registering the knee, telling the knee where things are, telling the robot where things are. It marries that information with what it knows from the CT scan, and then it can tell you where it knows where things are in space after that. Okay, go ahead. Okay, so once we get the points registered, you can click through these. Yeah. Yeah. Can we do the ligament thing? Okay. So now, see how it's moving with the knee? We've got to make sure we can see everything here. So now we can real time see where the ligaments are tight and where they're loose. And based on ligament balancing, we can make fine adjustments of the sizing and positioning of the implants to maximize or to make the best, to optimize your ligamentous balancing and implant positioning so that your knee moves smoothly. This is the step where AI is going to take over. This step where I assess where the knee is and how tight it is and how it's moving, we use that information to make decisions on how to change the implants to optimize the outcome. AI can make that step go from about a 10-minute situation to about 2 seconds. And it will come back with a plan and a couple of options, and then I get to choose those options. And what that does is it speeds up the surgery so you're under anesthesia less. It cuts down the infection risk because the surgery's quicker. And then it also does something that's interesting. If you have surgeons with varying degrees of experience with knee replacement surgery, it can make those surgeons all kind of the same. And it can raise the level of sort of aptitude of surgeons with less experience because AI is helping them make decisions that are correct, okay? But certainly we always, have the option of accepting or going with our own plan. So once we make the plan and accept where we want the implants, then we can make our bone cuts, okay? So should we take this off?
Right here, we'll do that. Saw blade.
Yeah.
Rub on the saw blade.
Okay.
Take that saw blade out. And then bring the probe on the.
Okay, this is where, now, we're gonna make a mock cut just because this is a saw blade. We don't want to make a big mess, but this is where the technology comes in, okay? So you see, this arm is moving where the femur is. And it gives me a visual and tactile feedback of where the cuts are being made. And if you'll see, there's a boundary there that's digital. I can't go beyond that boundary. So if there's a structure behind there, like the popliteal artery or the posterior cruciate ligament, it won't let me hit that, okay? We're trying to get in there between the collateral ligaments, and we don't want to go beyond a certain point. So this is a safety device as well. Think of it as a digital guide, like those metal guides we used to use. This is the same thing, it's just digital. So notice that this is coming into place, I'm making cuts. If I move it slightly, it stops. It doesn't like it, so it stops. If I extend it slightly, it moves with the knee, see that? Or it stops. So we get it into position. And we make our cuts. So once those cuts are made, they're all made in a specific angle and to fit the implant that we had planned, and that caps your knee just right, and it fits just perfect on there, okay? So we end up with a truly custom implant, a custom surgery based on your anatomy, based on your ligamentous balancing. So the end result is that you have a knee that moves well, that flexes all the way. Now, just a little editorial. Before we leave the operating room, we make sure that the knee can fully straighten and fully bend, and that everything's lined up and the ligaments are equal, that everything's balanced so it moves smoothly. That's step one. And I tell my patients that knee replacement surgery is a team sport, and we're on a team, right? And Once the surgery is over, now it's your turn to shine. And you can think of a knee like pouring cement. You have a certain working time to get that cement the way you want it, and then it just kind of sets up, and that's what you got. Knee replacement surgery and scar tissue is the same way. We put the knee in and close everything up. You've got to do your exercises and get that thing moving. There's about a 6-week window. 2 weeks, the first 2 weeks is crucial. If you can get your range of motion back in the first 2 to 6 weeks, then you're golden. If you go home after surgery and just lay in the recliner and don't do your exercises, the cement sets up and you have a lot of trouble. And many people have heard of patients who've not done their exercises. It's really important to get your exercises in early so that you can have a great result. Great question. The question is, do all orthopedic surgeons use robotics? And how do you know if your surgeon uses robotics? You have to ask them. In the Treasure Valley, so let me just tell you, Saint Al's, I love Saint Al's because they were the first organization in the valley, in the Treasure Valley, that had a Mako robot. This happened in like 2010. They bought their robot to do partial knee replacements. The first total knee went in 2016. The first robotic total knee went in 2016. We already had the robot. We bought the software just after that. We were putting these in like crazy, you know, in like 2017, 2018, 2019. In the Treasure Valley, the Mako robot is really popular, and about 70%, I think, of surgeons in the Treasure Valley are doing robotics, which is great. Nationwide, that number is about 40 to 50%, and it's going up from there. There's different robotic platforms out there. Mako is the oldest, and in my opinion, has the best technology. There's ROSA, there's other robotic platforms that other manufacturers have made. It's just that Mako is probably a good 5 to 7 years ahead of everybody else in technology. And as you know, in technology, that's light years. And so the others are just trying to catch up. It's the only one that I know of that has a primary arm that comes in and makes the cuts. The other robotic platforms are still navigating placement of the old guides, and then you put those in and make the cuts with the old saw blade. Another question. Yes, ma'am. Purple. Oh, I'm sorry. Go ahead, and then the purple, yeah.
Sorry. Do most insurances cover this procedure?
Great question. The question is, do insurances cover robotic surgery? The short answer is yes. And the reason is we don't charge anymore for this. This is the same CPT code, the same surgical code as knee replacement. If you get your knee done with 1980s instruments versus the up-to-date robotic technology, it's the same surgery. And so yes, the only thing that some insurance companies are not covering, and we're seeing this change, is the CT scan that you need to get before the surgery. That's a charge that didn't exist when we were using the old instruments. And so while most insurance companies are covering that CT scan, some insurance companies aren't, saying that robotics is still investigational, which it's not. And so they're not covering that. The good news about here in Boise is that we have a way to get your CT scan for a very reasonable price. For $175, you can pay cash if your insurance company doesn't cover it, and you can get your CT scan and then use your insurance for the robot surgery. I know it's a big number, but normally CT scans cost about $1,500, so it's a good deal for medical stuff. But you can still elect to have that surgery even if your insurance company doesn't cover the CT. Does that make sense? Okay, yes, ma'am.
Dr. Foote.
Yeah.
Randy had surgery done November 1st, 2023. And my curiosity, can you tell me what he might have, how you might have done? I know he had the tendon, but were you able to use that machine at that time?
Okay, so surgery in 2023.
November 1st.
Right, we were using the robot, but we weren't doing the muscle sparing approach.
Right.
The muscle sparing approach came about because of, to be honest with you, when the Jiffy knee came out, we were like, what is this? And we looked at it and we're like, oh, it's the Southern approach or the old muscle sparing approach from the early 2000s. How can we use that to benefit patients but not fall into the problems that we had before with alignment? And just the Mako surgeons kind of got together and decided, you know what, we're going to, couple this with the robotic technology. And so that we've just been doing that now for about a year. So, but it's really working out great.
Well,
So,
it sounds like it's a
yeah, yes, sir.
So the AI technology, does that help with the healing and flexibility of your knee more so than the old method?
So the question is, does the AI part of the procedure help with flexibility and the outcome of surgery? To answer that, let me just tell you one thing that's true about knee replacements that's not true about hip replacements. We have a thing we call as surgeons surgical forgetfulness, okay? That's our goal with a patient with surgery is surgical forgetfulness. That means the point in time when you forget that you had surgery, the point in time where you wake up in the morning and that's not the first thing you think about. The point in time when you wake up in the morning and say, you know what? This is my hip, right? It got replaced, but it feels great. It feels just like my hip. The rate of surgical forgetfulness and the time from the surgery time to the time when you get to there in hip replacement is short, and it's like high rate, like 90-something% of people get there with hip replacement. With knee replacement, it's only 70% of people ever get there. And so that's why when you talk to people that have knee replacement surgery, most of them say, yeah, it's great, I wish I would have done it earlier, but a few of them say to you, you know what, it still hurts, it's still this, it's still that. And I think after look, I try to get better with each surgery. I feel like I learn something from each patient. I feel like I learn something from each patient where I do something in the operating room a certain way and I see the outcome afterward. I think the muscle sparing thing is a big deal, okay? Because I see it making a difference. But the knee is complex. It's more complex than the hip. There are certain balancing issues that we run into with the knee where, it's not a perfect round ball on the bottom of your femur. It's a can, meaning it's shorter on the distal end and longer on the posterior end. And so the complex relationship between the ligaments and the shape of your knee is difficult to kind of reproduce with any surgery. But this is getting us there. And to answer your question, I think that these decisions that we make once we get into the operating room and see where your ligaments are, we already know how big your knee needs to be, right? It used to be that a lot of knees were going in that were oversized or undersized. We've solved that problem. We put the right size in because we know within millimeters how big your knee is before you make an incision. What we're trying to do now is fine-tune the balancing. And with AI, it's helping us make decisions in a reproducible manner. Let's say I get inside your knee and you're loosen extension, tighten flexion, a little bit loose on the left side, tighter on the right side. We can make fine adjustments of the implants and still not go outside of alignment problems and get a good result. But to get there, we have to move the tibia here, make the spacer a little bigger, move the femur anterior 2 millimeters. There are these complex sort of. And when I was just at a Mako Champions course where they have surgeons that do a lot of Makos, and we went to Phoenix and we had this big meeting, and we had a scenario from the operating room where, what do you do if you get this, where you have this patient that has this problem? Where do you make your adjustments to make the outcome good? 3 experts did 3 different solutions. So what AI is going to do, it's going to make those all the same, and it's going to help us make decisions that are the same every time, reproducible results, keeps us lined up, gets us balanced, and gets us there. For a surgeon that does 1,000 total joints a year and a surgeon that does 100 of them. So that's, I think, where we're headed. But we're learning all the time. And we started in the 1974 with Dr. Insall, just kind of going in there and just kind of like, looks good, put the knee in and hope you do well, you know? And people did pretty well. But now with all of this technology, we're really fine tuning it. We're hoping that we take the 70% of people that get to surgical forgetfulness and knee replacement surgery, and we make that 90%, just like total hips. So that's where we are. Any other questions? Yes, sir.
Yeah, when you use this and you have your recovery time, which we're hoping for that 2 to 6 weeks, is the pain level less than traditional knee replacement surgery?
So you're talking about, so the question is, if you use this technology, is the pain less than the old way, right? Okay, let me tell you what the literature shows. The literature tells us that at 6 months, muscle sparing versus robotic versus the old school implants. Well, I should say this. The literature tells us that the muscle sparing versus the traditional approach at 6 months is the same, okay? However, the first 4 to 6 weeks, much better with the muscle sparing approach in terms of pain, the ability to get range of motion, the strength of your quadriceps. Any orthopedic surgeon who's done any surgery will tell you that if you mess with someone's quadriceps tendon, their quad shuts down for weeks. And it's hard to get that muscle to fire. We literally see people in the recovery room with full muscle strength because we haven't cut through that tendon. So to answer your question, what's the difference? The difference is the pain level in the first 6 weeks. And even though the results are the same as you measure them with whatever metric you're using at 6 months, think about how much better you're going to do if you're having less pain. You'll push your knee more to more motion, and I think that your personal individual result will be better. And even though we haven't been able to show that at 6 months, we have been able to show it in the short term, and I think that makes a big difference. If you have in your mind that this thing is going to hurt like crazy for the first 6 weeks versus maybe it won't be so bad, you're much more likely to do the surgery, I think. So, yes, sir.
So with the robotics and the exact precision that you're getting out of that, and the less invasive stuff to muscle tissue and such, you're getting better results for cooperation for your patient as far as they're doing the follow-up exercises and things like that, or is that still? I think,
so the question is cooperation on the patient side, is their part of the team, better with this sort of stuff? And the answer is, I think so, yes. Now, you still see patients that just, they think, they have this idea that surgery is just one point in time, and then, there's no buy-in. And we try like crazy to try to educate patients. We have an hour-and-a-half long class that you can attend that helps educate you about what to expect and to try to get you to understand that, it's a 50-50 team approach, So to answer your question, I think so, but there's always, I think, going to be some apathy out there in terms of your desire to,
overcoming that apathy or overcoming the fear of pain by the patient to actually cause them to go out and challenge themselves to do the exercises. Because I've had a number of surgeries that were not joint related, but the thing that I found that has always helped me the most was while I was driving the nurses crazy by getting up with my IV poles and walking down the corridors while still under anesthesia, it helped me recuperate and I got back faster.
Yeah, his point is that the harder you work early on, the better you're going to do, and that is absolutely true. Any other questions in the back? Let's go in the back. Yes, sir, with the glasses. Yeah.
How long is it before you can resume normal activity?
Great question. So the question is, after knee replacement, how long between the surgery and resuming normal activities? Okay, I'll give you two scenarios, right? Worst case, best case. We used to tell people it was 6 months before you're back to, doing most things. I think nowadays, if you are aggressive and if you take advantage of the new technology and doing things the way that we're talking about, You can expect to go home the same day, okay? Use a walker or crutches for about a week. Start your range of motion right away before you get into physical therapy. Drive in 2 weeks. The criteria for driving is off pain medicine and full movement and use of your knee so that you can safely use the controls of your car. Obviously, the right knee is going to take a little longer than the left knee to get there. 6 weeks, I think you can be mowing the lawn or traveling. And then it still takes some time for these knees to sort of settle in. And I think that is different for everybody. It can be 4 months, it can be a year until you get to surgical forgetfulness. But my goal is for everyone to get there. Not everyone does. That's just the way knees are. But my goal is for everyone to get there. Yes, ma'am.
Is there ever any rejection of the body to the metals or the plastics?
That's a good question too. So the question is there ever any instance where you see a medical or a biological rejection of the implants? There's been a lot of debate about this, and we could talk about this for an hour, but there are thought leaders that feel that there are patients who are allergic to the metal. The implants that we put in are cobalt chrome, so they're a metal alloy similar to stainless steel that contain nickel, and they contain chromium, and they contain other metals that people can have allergies to. And so if you have a patient that has some swelling after knee replacement surgery, that could be a possibility. If you have a severe allergy, if you know you have a severe allergy to metal, you should probably tell your surgeon. There are metals that we can use in place of the cobalt chrome implants. The problem with those implants is the longevity isn't there, and so if you start to use metals that aren't as strong, that they can loosen or wear out quicker, and so we only do that if you have a known allergy. I will say this about metal allergies: there are a lot of thought leaders in our business and our medical specialty that aren't convinced that exists. Personally, if you come into my office and if you have a documented nickel allergy, I'll use what I call a hypoallergenic metal. We can't use the robot with that metal because it's made by a different manufacturer. Stryker, the people who manufacture the Mako, their instruments are proprietary to the Mako, and so you have to use a Stryker knee. So it's called a triathlon knee. Very good knee. It's been around for years. It's just designed very well. It works well. They're coming out with a new hypoallergenic knee. It's made of gold. It's literally gold. It's a gold mixture. Like, it's not pure gold, but it has gold in it, and it's going to be great. It's going to be for those patients who have that problem. So there is a solution for those who have that problem. I personally feel like it probably exists. It's not very common at all, but we have a way around right now, and eventually we're going to be able to use the robot with that. Someone in the back. Yes, sir. Oh, yeah, you already had your turn. Yes?
Can you do both knees at the same time or only one knee at a time?
Good question. So the question is, can you do bilateral knees at the same time? The answer is yes. There's certain criteria you need to make. First of all, you have to have no cardiac history. If you have any cardiac history at all, you're not a candidate, because single knee replacement is taxing on your system. Double knee replacement, where we do one knee, reprep, redrape, do the other knee, that's a lot of tax. It taxes your system. And if you have any coronary artery disease, valvular disease, or any cardiac history at all, it's just too much risk. So that will disqualify you. You have to be fairly young and healthy and able to, and have the right mindset to do that. Some of my happiest patients are patients that did bilateral knee replacements at the same time. However, I only do it if someone comes to me and says, I want to do it. It can't be my idea. They come to me, they've got their mind made up, I want to do both knees. it takes that kind of attitude, like, I'm gonna get through this, because you literally don't have a leg to stand on for a couple of days. And so you gotta be super tough, but it is possible. And I've done a lot of them, yeah. Yes, sir, with the hat.
If a patient, through their therapy for unknown reasons, mental or physical, is able to not do the therapy and they have problems, how is that repaired?
So the question is, if someone gets into a situation for a medical issue or another issue where they can't do the rehab, how do you deal with that? So that's a great question. And there are times if someone has, let's say someone were to have like a heart problem after surgery and they were ended up with, or like a GI bleed or something bad where they have to go back in the hospital after knee replacement surgery. A lot of times they aren't able to do the exercises. Those patients sometimes do okay. I personally think that scar tissue inside of your knee has a pretty strong genetic component. I think people are more prone to growing scar tissue. And so there are certain patients that are more prone to it. And if you're not one of those patients, you may be okay if you have that happen to you. But a lot of times patients in that situation will get a condition we call arthrofibrosis, which is essentially just a knee that gets scarred up. In those patients at 6 weeks, we can do what we call a manipulation under anesthesia, where we can put patients to sleep, manipulate their knee into full flexion so that we regain the motion that we had at the time of surgery, manipulate their knee into full extension, and then put those patients into therapy, and they end up doing okay. Yeah. Yes, ma'am.
Did your weight really have a...
Great question. Yeah, I'm glad you asked that. How does weight relate to knee replacement surgery? Up until about 2 years ago, there was a thought that anyone with a body, we look at weight as body mass index. It's a weight to height sort of measurement, and the body mass index, a body mass index of greater than 40 was always thought to be sort of the cutoff for when we could safely do knee replacement surgery. It was an fairly arbitrary cutoff, but there was a big push up until about a couple of years ago to say no to patients who had a BMI of over 40, because the thought was that if you are heavy, that you could have complications, heart and lung complications, wound complications after surgery. What happened was a few years ago, there were a bunch of studies that were done comparing patients with body mass indices that were in the normal range versus over 40. And we found that basically there was a slightly increased risk of complications, but that risk was reasonable, and that most patients, if that was their only risk factor for complications, like if they had a healthy heart, didn't have out-of-control diabetes, were non-smokers, and if that's your only risk factor for having problems, that knee replacement surgery can safely be done in patients with a BMI of over 40. And so we'll routinely do patients with BMIs of 42, 43, 45, 38. Once you get up to 49, 50, it becomes just more of a problem with positioning and that sort of thing. And so I think there is still a cutoff. Where that is a hazy line nowadays, but you can safely do it in higher BMIs. Yeah. Yes, ma'am.
What is your philosophy after knee replacement on kneel?
Okay. The question is, what is my philosophy on kneeling? Look, I don't give anybody any, black and white restrictions after knee replacement surgery. Once you've recovered, I tell people do what you're comfortable with. If it hurts, change what you're doing, maybe do something else. Kneeling is probably the last thing that comes back after knee replacement surgery. It takes people between 8 and 12 months to get there. You can kneel up as long as you use a pad before that time, but kneeling comfortably is probably the last thing to come back. It does come back though, and I'm okay with it. I do think it's nice to wear pads if you're kneeling for long periods of time after knee replacements, because if you think about it, you have a metal implant that's under the skin, that's not too far away from the skin. And if you kneel on that for a long period of time, it can cause some pressure problems. So pad it up and go for it. Yeah. Yes, in the back, standing.
Do you do surgeries for the Veterans Administration?
Question is, if we do surgeries for the VA, the answer is yes. We don't operate at the VA, but we a lot of times will get overflow from the VA where patients will get a release from the VA to have their benefits taken care of in the community. You just have to talk to your provider about that. If the line's too long at the VA, you can. There is a mechanism, and I'm an expert on it, but I have worked at a VA in training when I was training, and so I know that does happen. And you just have to talk to your VA provider to see the mechanics of getting that done. But they essentially give you a voucher that you can take out to the community and get your knee done. Yeah. Yes, sir.
You do the surgery here in Nampa, and also how long does it take?
Question is where we do the surgery and how long it takes. We do the surgery where the robot lives. We have a robot in Nampa here. We have a robot at the 10 Mile Surgery Center. St. Al's bought the old Salsa Surgery Center in the parking lot at Shields. And so we now do outpatient knee replacements there. St. Al's bought a robot and put it there. And then we have a robot downtown too. But I personally operate here at 10 Mile Surgery Center. And the surgery takes, so knee replacement surgery, skin to skin takes me 60 minutes. So it's about 35 minutes of tourniquet time, and then we have to, put the implants in and close things up. So it's about 60 minutes. And we do 5 or 6 a day. We don't like to do a ton of them. We like to take our time and get it right. Yeah. Yeah.
Does Mako use its own knee, or is it the same mechanism that you use in other surgeries?
So is the question, do you have to use a specific knee with Mako? Yeah, so the question is there a proprietary knee that you have to use with Mako? And as it stands now, the answer is yes. The knee replacement that goes with this technology is the Stryker Triathlon knee. Great track record. Most companies have their own proprietary knee that goes with their robot. There's about 5 major orthopedic companies and I think 4 robotic platforms that are, I think, worth looking at. Again, my opinion, Mako is just ahead of the game, and it will be for the near future. So, any other questions? One more here. Let's go 2 more questions and then we'll wrap up. Yes, ma'am.
This is being recorded. Will it be uploaded online so that we can watch the demo later?
So I'm not sure where on the website, but we'll make sure it is. But yes, our plan is to be able to have you access this online somewhere on the St. Al's website.
We'll email everybody the link.
Okay, Beck says we're going to email everybody the link. So if you gave your email address, you'll get a link to this. Yes.
On the tourniquet that you use
Yeah.
during the surgery,
Mm-hmm.
does that ever leave a problem with the leg afterwards for a long time or a short time?
The question is a good one. These are great questions. So what does the tourniquet do? We like to use a tourniquet just so we have a bloodless fill that helps us see things better. There are some drawbacks to long tourniquet. I have not seen a lot of problems with the tourniquet because we only have the tourniquet up for about 30 minutes, 35, 40 at the most. In revision situations, it can be up longer. The tourniquet can cause problems if it's up for, an hour and a half, 2 hours. It can cause bruising in the thigh. If you have peripheral vascular disease, it can compress the vessels and cause some issues. We can do a tourniquetless knee as well. It's a little bit harder to see, but with the robot, we're in good shape. And we do that in patients who request it or if they have peripheral vascular disease. So great question. So the bottom line is if you use it the right way and don't use it for a long time and you don't put it up real tight, then you're in good shape. One more question and we'll be done. No? Oh, thank you. So, one more, yes.
Okay, if you're on a blood thinner, how long do you have to be off for it before you can do the surgery?
The question is, if you're on a blood thinner, how long do you have to be off of it before doing the surgery? And the answer to that question is depends on the blood thinner. For Coumadin, it's about 3 to 4 days. For Apixaban and some of the newer factor 10 inhibitors, like the newer novel Eliquis, those you have to be off for 72 hours for a major surgery like this. Aspirin, it's about a week. So that's it. Okay, one more question, then we'll be done. Yeah.
I'm on Prevnar because I have RA.
Yeah.
And I've been told just about by every doctor that that's a blood thinner also.
So prednisone, the question is it a blood thinner, and what do you do with it during surgery? It doesn't usually have an effect on coagulation, and you do not have to stop that for surgery. Okay, thank you very much, everybody. I appreciate your assistance, for your attendance, and it's been great. Thank you so much.